Unfortunately, it's not. All right, we're good to start?
Yes.
All right. So we'll talk about eosinophilic lung diseases today. Objectives are to describe the eosinophil and its role in various lung diseases. We'll give an overview of the eosinophilic pneumonias, differentiate primary from secondary eosinophilic lung diseases, and then have a discussion of lung-limited acute and chronic eosinophilic pneumonias. And then lastly, we'll talk about some of the systemic pulmonary eosinophilic disorders, including EGPA, or previously known as Church-Strauss. If we have time at the end, we can discuss some of the secondary eosinophilic lung diseases. One of them, ABPA, we talked about when we did the bronchiectasis talk, and I know Dr. Eloy discussed it a bit when he did the asthma talk, so I'll probably skip it today. Then we'll do Loeffler syndrome, or simple pulmonary eosinophilia, and tropical pulmonary eosinophilia. We'll see if we have time. So the eosinophil, my favorite white blood cell. It is a multifunctional leukocyte. It has a bilobe nucleus, and it has the characteristic pink-orange granules, which are the cytotoxins that are released when the eosinophils are stimulated by cytokines, interleukins and all.
Which interleukins?
Which ones?
Question?
So that's an important question, actually. We're going to talk about that a lot when it comes to different treatment options. But the main interleukins that are involved are IL-5, IL-4, and IL-13. IL-5 is the main one that's involved in synthesis, maturation, differentiation of eosinophils. IL-4 and IL-13 are more involved in preventing apoptosis, so in prolonging survival of the eosinophil. So you can imagine that having drugs that target those interleukins may have some role in these eosinophilic lung diseases, and of course, eosinophilic asthma, but that's not the topic today. So these eosinophils, again, they have these several granules. They participate in innate and adaptive immunity, and they play a key role in the inflammatory reaction associated with certain infections, especially parasites. And in fact, the eosinophilic pneumonia, the most common worldwide cause is really parasitic infections. Like we talked about, the eosinophils develop in bone marrow under regulation by IL-5. It participates in eosinophilic maturation, differentiation, recruitment, mobilization, activation, and inhibition of apoptosis. And like we said, IL-4 and IL-13 also participate in eosinophilic activation and inhibition of apoptosis. So what are in the granules? These are toxic eosinophilic products released upon cytokine stimulation. They have direct cytotoxic effects on different organs. So, for example, the one that's known to have direct cytotoxic effects is the eosinophilic cationic protein, which can have direct cytotoxic effects in the heart, the brain, the bronchial epithelium, and several other granules that are involved. And like we talked about, the major cytokines that are implicated, and these are always on the boards, in the recent boards at least, there's IL-5, which is the major one involved in the synthesis and the development of eosinophils, and then IL-4 and IL-13. So you can imagine if you have a monoclonal antibody that's targeted against IL-5, such as mepolizumab, or the IL-5 receptor, such as benralizumab, that you can profoundly decrease the synthesis maturation of eosinophils, and you can cause eosinopenia, just by blocking the IL-5 itself, or the IL-5 receptor. On the contrary, if you have a monoclonal antibody that binds to IL-4 and IL-13, such as dupilumab or Dupixent, dupilumab will bind to the IL-4 alpha receptor subunit and block the effects of IL-4 and IL-13, and this will result in increased apoptosis, because it's going to prevent the inhibition of apoptosis, so it's going to induce apoptosis of the eosinophils. So these are the major cytokines involved. So just some notes regarding eosinophilic toxicity. This is very, very important, because you'll notice a lot of these eosinophilic lung diseases are very steroid responsive. You can cause remission very quickly just with steroids. And it's usually reversible with treatment, but it's important to note that tissue damage and remodeling with fibrosis can develop in certain states, because eosinophils also secrete TGF-beta, which can cause airway remodeling and fibrosis. This is most important in these two eosinophilic lung diseases, allergic bronchopulmonary aspergillosis and eosinophilic granulomatosis with polyangiitis. So how do steroids actually work? They reduce eosinophilia, and the way they do it is one is they shorten the half-life of cytotoxins. So if you're shortening the half-life of IL-5, IL-4, IL-13, you can imagine that you're going to inhibit the cytokine-dependent survival of these eosinophils. And so you'll notice if you put somebody on steroids, immediately they become eosinopenic. So just a quick overview of the eosinophilic pneumonias. The honest truth is the histopathology is essentially the same in most of the different causes, and identifying the etiology must be obtained by history, physical associated findings, etc. So chronicity is very important. Is it systemic or is it lung limited? Are there other, for example, ANCA positivity, ANCA is negative, or ANA, is this a connective tissue disease, etc. And at a pathologic level or a histopathologic level, the alveolar space is filled with eosinophils, but you can also have macrophages, multinucleated giant cells, and an interstitial cellular component that is present as well. And then you'll see, I don't know if this comes up on the boards, but you can have eosinophilic microabscesses. And in the majority of cases, like we said, and this is very important, the lung architecture remains intact without fibrosis or necrosis, except in some of the chronic conditions, AVPA and EGPA being the most prominent. And you can also have a non-necrotizing eosinophilic vasculitis may be present. The only type of eosinophilic lung disease that causes a necrotizing eosinophilic vasculitis is EGPA. Yeah, very good. Very importantly, this sometimes can come up on the boards, but acute eosinophilic pneumonia, which is a lung-limited form of eosinophilic pneumonia that's acute in onset, may also be accompanied by diffuse alveolar damage and organizing pneumonia. I'll show you some pictures. So this is a classic alveolus here filled with these, I guess it's hard to see from far away, but these are a lot of these eosinophils. See these bilobe nucleuses, pink-orange cytoplasm. So this is, a classic example of an eosinophilic pneumonia. You can also have a non-necrotizing vasculitis where you see eosinophils in the arteriolar wall. If you look here, you can get some fibrotic responses as well, rarely, but this is an important slide here. This is, your hyaline membranes and your organizing pneumonia pattern that can be present in cases of acute eosinophilic pneumonia. So how do these patients present? The classic symptoms, cough, dyspnea, wheezing, sometimes can have pleuritic chest pain. They get pulmonary opacities on chest imaging. And then I think it's very important to note that they all will have pulmonary eosinophilia, meaning their BAL, if you do a BAL cell count, they will have BAL eosinophilia. However, pure peripheral eosinophilia is not mandatory for all of the eosinophilic pneumonia. So for example, in acute eosinophilic pneumonia on presentation, there is no peripheral eosinophilia on presentation. In fact, they have a neutrophilia. And when you bronch them, you'll find greater than 25% BAL eosinophils without peripheral eosinophilia. So it's one of the differentials you have to think about in somebody who comes in with idiopathic ARDS, right, on the board. So just some definitions important to note. Blood eosinophilia is greater than 500 per microliter. So when you're looking at the CBC and it says eosinophils are 0.5, that equals to 500 per microliter. Note this is a little different than asthma. So eosinophilic asthma is greater than, the cutoff is 300 per microliter. So that's eosinophilic asthma. But blood eosinophilia by definition is greater than 500 per microliter. And hypereosinophilia is considered greater than 1500 per microliter. And like we said, again, peripheral eosinophilia is not necessary for the diagnosis of eosinophilic pneumonia, but assists in identifying the etiology. So let's quantify pulmonary eosinophilia on BAL. Normal is less than 1%. And these are memorizable numbers. Chronic eosinophilic pneumonia is greater than 40%. Acute eosinophilic pneumonia is greater than 25%. And then it's important to note that in some etiologies, you can have 3 to 10% BAL eosinophilia without having a primary eosinophilic disorder. So for example, in IPF, in ILD due to connective tissue disease, hypersensitivity pneumonitis, sarcoid, even cryptogenic organizing pneumonia, I didn't write it here, but you can have it with that as well. Radiation pneumonitis, you can have this mild BAL eosinophilia. Again, it's greater than 40% for chronic eosinophilic pneumonia and greater than 25% for acute eosinophilic pneumonia. So let's talk now, when you talk about eosinophilic lung diseases, you have to differentiate primary versus secondary. So we'll talk first about secondary, but our talk today is going to be mostly on the primary. But the secondary eosinophilic lung disease is associated with a specific etiology. So, for example, the most common cause being infection. And the most common infections are going to be your simple pulmonary eosinophilia, also known as Loeffler syndrome. And you guys know how that develops. These are patients, you ingest the eggs of these parasites, these helminths. It's usually Ascaris, hookworm, strongyloides. What was that? Paragonomyces, yeah. And you ingest the egg, and then in the intestinal tract, the eggs hatch, and the larvae penetrate the intestinal mucosa. They eat away. They enter into the bloodstream, and then there's this transpulmonary migration from the bloodstream into the alveoli. And then at the alveolar level, these larvae start to mature, and then they ascend up the respiratory tract. They come, then you could swallow it or pop it up, whatever it is. Very descriptive. There you go. You get the tropical pulmonary eosinophilia, which is your filaria or Wucheria, Bancrofti, and all these other stuff. And then, of course, drug-induced is important. I know Samir talked about this a few weeks back. Connective tissue disease, sarcoid, COP, etc. And then the primary ones, which we're going to talk a little bit about today.
Nina, are there any drugs that particularly have risk to this?
Yes.
What are they?
So the most common one and the most tested one is daptomycin.
Okay.
So prolonged duration of daptomycin can cause a significant eosinophilic pneumonia.
That was on the boards.
That was on the boards, right?
Yeah.
And it's usually more than like 3 weeks duration of therapy. If somebody comes in with acute eosinophilic pneumonia or ARDS pattern on daptomycin, it's one thing to consider. The primary eosinophilic lung diseases are idiopathic. They're less common, very rare actually. So for example, like EGPA is 3 per 1 million people will have EGPA, so very, very rare. It can be lung limited. So the lung limited ones are your acute and chronic eosinophilic pneumonias, or they can be associated with systemic disorders. These are your EGPA and hypereosinophilic syndrome. Again, hypereosinophilic syndrome is very rare. It's rarely on the pulmonary boards, but I believe we had a question on the echo boards with the mural thrombus.
Yes.
If I'm not mistaken. What was that?
The question.
Yeah, like a decreased, a normal LV function, but with a mural thrombus. So then the question is how to differentiate primary versus secondary eosinophilic lung diseases. And again, it's going to be mostly based on history. So occupational environmental exposure, travel, medications, like we were saying, B symptoms, and asthma histories. So for example, and this is also comes up on the board, chronic eosinophilic pneumonia and EGPA will very commonly have an associated asthma history as opposed to acute eosinophilic pneumonia where these patients do not have an asthma history. Systemic findings, for example, EGPA has a lot of systemic finding, cardiac involvement, rhinosinusitis, neuropathies, etc. And then chronicity is very important for evaluating these patients. You want to look at imaging, X-ray, CT chest, and imaging is very important because you want to look at where's the distribution of disease. So, for example, in chronic eosinophilic pneumonias, you get that negative bat wing pattern or the photonegative pulmonary edema where you have these peripheral opacities with central sparing, as opposed to acute eosinophilic pneumonia where you can have diffuse opacities. You want to, if these patients are having chronic eosinophilic pneumonia, you want to look at EFPs, is there reversible airway obstruction? You want to look at the CDC with differential. Again, very importantly, not all pulmonary eosinophilic diseases have peripheral eosinophilia. And then ANCA and autoimmune serologies may be important here to help out. Lastly, a very important point is these patients will always bronch them. We'll do a BAL. And the question always comes up, do you need a biopsy? And a lot of times we get a biopsy because we don't know that they have eosinophilic pneumonia at the time that you're biopsying them. But if you have a suspicion for eosinophilic pneumonia or chronic eosinophilic or EGPA, they don't necessarily need a biopsy, actually. And for acute eosinophilic pneumonia, a BAL should be sufficient. A BAL cell count would be most important. So this is kind of an overview of the eosinophilic lung diseases. You have the lung-limited, acute and chronic eosinophilic pneumonias. And then you have the systemic EGPA and hypereosinophilic syndrome. And then you have the secondary etiologies, like we talked about, Loeffler syndrome, tropical pulmonary eosinophilia, ABPA, drug-induced, etc. So here's the first question. 21-year-old man awakens from sleep with acute onset dyspnea, pleuritic chest pain, dry cough. He feels warm with a sore throat and myalgias. He was well the previous day. He has not had any sick contacts, no recent illnesses. He started smoking cigarettes 2 weeks ago. He does not have any recreational substance abuse and rarely drinks alcohol. He is not sexually active. The vital signs are as follows: temperature 37.3 Celsius, heart rate 107, blood pressure 106/65, respiratory rate 42, sat 97% on 2 liters. He's in moderate respiratory distress with rapid shallow respirations, 2 to 3 word responses, no JVD. He has diffuse inspiratory crackles on exam. Remainder of examination is normal. This is the initial chest X-ray on presentation. So it looks pretty okay, nothing crazy. Lab studies reveal a normal D dimer, white counts 15, is a normal differential, a normal serum lactate, LDH, negative HIV rapid. He's admitted to the hospital, empirically treated for community-acquired pneumonia. Over the next 6 hours, he progressively deteriorates, becomes febrile to 39, transferred to the ICU, gets intubated for hypoxic respiratory failure, and a repeat X-ray is obtained. And a diagnostic, he is intubated and a diagnostic procedure is performed. This is his follow-up X-ray.
6 hours?
So he goes from this to this without 9 liters of fluid resuscitation. What should be done next? Treated fully for cold. Got toasty.
Perfect. Okay.
You want a BAL? Okay.
Yeah.
CT of the chest.
If I do the BAL. B for Adam. Season.
B for Adam. B for Adam.
You use the second answer to whatever the first answer is.
Or surgical lung biopsy. So C is the correct answer. And this is a case, and the trick here is that they tell you that the differential is normal on presentation. And the other clue that they gave us is that he recently started smoking cigarettes, right? That's a giveaway. So it's AEP, yeah, acute eosinophilic pneumonia. And the BAL here is diagnostic. You know, to be honest with you, sometimes the presentation is not so clear cut. So these patients, you know, you intubate them, do BAL and a transbronchial. It depends if Fiore is there or not. But anyways, you know, a surgical lung biopsy is not really required for these patients. So let's talk about the primary eosinophilic pneumonias. The lung limited. The first one is acute eosinophilic pneumonia. The key features is the acute onset within 1 week usually of fevers, radiographic opacity, severely hypoxemic, looks like ARDS. Most of them require mechanical ventilation, and AEP should be in the differential for idiopathic ARDS. And again, very importantly, usually no peripheral eosinophilia on presentation with greater than 25% eosinophilic alveolitis on BAL. Very importantly here, and this is a distinguishing feature compared to chronic eosinophilic pneumonia, is that these patients, once you treat them, they have no relapse after recovery. These are the diagnostic criteria, like we said, acute onset. Less than 1 month is written here, but it's usually less than 1 week. Diffuse bilateral opacities, hypoxemia with a PF ratio less than 300, or SAT less than 90%. And like we said, pulmonary eosinophilia with absence of infection or other known cause of eosinophilic lung disease. So for example, you want to rule out drug-induced eosinophilic pneumonia.
Was this described with vaping, vaping lung eosinophilia or not?
We didn't really have much, although I did see case reports actually of eosinophilic pneumonia with vaping. So we never had any of those here.
But it's been described, hasn't
it? It has been described, yeah. With e-cigarettes, also World Trade Center exposures is another common cause. Another one that's been documented in the literature is military workers in Iraq during the war that were exposed to dust there. What was that? I don't know. Yeah. So again, the classic patient average age is about 30. Males greater than females. Again, no asthma history, and that's very important to contrast this with chronic eosinophilic pneumonia. And the key historical giveaway is recent exposure to dust or cigarette smoke. So for example, recent onset smoker less than 1 month, recent cave exploration, not sure who's in that, gas tank cleaning, indoor renovation, World Trade Center exposure, and like Dr. Mayo was saying, e-cigarette use. So let's talk about smoking and acute eosinophilic pneumonia. The classic issue is recent onset of heavy smoking. So actually a very important point is that these patients, you treat them, if you re-challenge them with cigarette smoke, they can have recurrence of the acute eosinophilic pneumonia. But aside from re-challenging, relapse is very uncommon with acute eosinophilic pneumonia. Contrast that with chronic eosinophilic pneumonia, where relapses are very common. Recent changes in smoking habits, so resumed smoking after a period of smoking cessation, or recently increased tobacco use. Passive smoking is also reported to cause AEP. Cocaine use is also associated with it. So here, the second question, this isn't a giveaway because we just talked about it, but we'll answer the question. The 21-year-old man spontaneously awoke with acute onset breathlessness, pleuritic chest pain, generalized bone pain. He was well the day before experiencing his symptoms, has no prior medical issues, started smoking cigarettes 2 weeks ago. He's not sexually active. It's very similar to the previous one. On arrival is moderate respiratory distress with a respiratory rate of 42, hypoxemic, setting 80%, and we'll look at the x-ray in a second. He deteriorated over the next 12 hours, hypoxic, intubated, vent support, repeat chest x-ray, we'll look at it. He was empirically treated for flu and community-acquired pneumonia and PCP pneumonia. Rapid HIV and influenza PCR were negative, and the BAL showed 40% eosinophils. So it looks like a case of acute eosinophilic pneumonia. We all agree? Rapid deterioration is x-ray. So the question is, which of the following best characterizes the clinical features associated with a likely underlying pulmonary disease? Prolonged corticosteroid therapy for 6 to 9 months is likely required. They may represent an acute hypersensitivity reaction to an inhaled agent such as dust, fireworks, medications, or tobacco smoke. The response to treatment is delayed, and most patients require prolonged ventilatory support. Or D, tolerance to the inhaled agent prevents recurrent episodes. B, very good. So just to go through the wrong answers, prolonged corticosteroids is unlikely to require. Usually these patients will require 2 to 4 weeks of therapy. Short course. Thank you, Ray. This is the correct answer. We just talked about that. And response to treatment is very quick. Within 2 to 3 days, they're off the ventilator, they're almost off oxygen, and radiographic resolution occurs within 1 to 2 weeks for the most part. And there's no such thing as tolerance. So re-challenging causes recurrent episodes. So B is the correct answer. So let's talk about the findings on chest X-ray and chest CT in these patients. So we talked about they have bilateral opacities, mixed alveolar and interstitial. Chest X-ray can show bilateral pleural effusions, curly V lines. On CAT scan, they can have ground glass opacities, consolidations, interlobular septal thickening. Pleural effusions are common. And very important to note, and this was pointed out in Murray and Nadel's, a young healthy male with bilateral pleural effusions, interlobular septal thickening with no history of cardiac disease should raise concern for acute eosinophilic pneumonia. Like we talked about, radiographic resolution is very quick, within several weeks, as opposed to other forms of pneumonia where it can take up to 12 weeks for full resolution. And the last finding to resolve is the pleural effusion. So you can see here, the diffuse bilateral opacities with rapid progression. You can see how they go rapidly to these diffuse, overwhelming opacities bilaterally. On a CAT scan, you can see how it looks like ARDS with the associated pleural effusions. You can get the interlobular septal thickening. You can see that up here. See all the interlobular septal thickening, ground glass, more consolidated opacities, bilateral symmetric, and it can progress very rapidly. Okay, it looks just like ARDS. Lab studies, we talked about initial absence of peripheral blood eosinophilia may arise during the course of illness, though. So if you do serial BALs and serial peripheral smears in somebody who's got acute eosinophilic pneumonia that did not get started on steroids, you'll notice that the eosinophil count will start to rise over time if they're not treated with steroids. Initially, just leukocytosis with neutrophilia. And the pleural effusions themselves also have a marked eosinophilia. If you check other labs, like of course the IgE is going to be elevated because they develop the eosinophilia, which will result in elevated IgE. And then we talked about the BAL eosinophilia. A lot of this is repetition, but the more we repeat it, the more it will stick. Very uncommonly, patients don't present with shock, and then they don't have any extrapulmonary involvement. It's single organ failure. And the last question is lung biopsy necessary for diagnosis of acute eosinophilic pneumonia? And the answer is no, it's not necessary. A BAL showing alveolar eosinophilia is sufficient for diagnosis, but the transbronchial biopsy will show eosinophilic pneumonia. And you just want to make sure you rule out the other infectious and autoimmune etiologies. Treatment, we talked about. It's very simple. It's just steroids. There's really no guidelines for dosing. Some people use 1 mg per kg. Some people do like a modified pulse steroids, like a quarter pulse steroid dosing. Has been documented 60 milligrams Q6 of Cymedrol, which is about 240 milligrams daily. And then once they improve, you can switch them to oral prednisone, and 2 to 4 weeks should be sufficient. Contrast this with chronic eosinophilic pneumonia, where they require a much longer duration of steroid treatment. If they don't require mechanical ventilation, then starting at half a mg per kg should be okay, or some people say 30 milligrams daily. But there's really no guidelines. It's each patient will be evaluated individually. Response to steroids is dramatic. Radiographic resolution is quick. And very importantly, very good prognosis with no relapse. All right, so that's the first cause is acute eosinophilic pneumonia of lung-limited primary eosinophilic pneumonias. The second one, if it's not acute, it's going to be chronic. So chronic eosinophilic pneumonia, we'll ask a quick question. Which of the following statements about chronic eosinophilic pneumonia is true? A, the chest radiograph findings of dense, extensive, bilateral, peripheral infiltrates are present in the majority of patients at the time of presentation. B, coexistent asthma is common. C, definitive diagnosis requires a lung biopsy. D, the majority of patients will require lifelong treatment with glucocorticoids.
B.
B, very good. So coexistent asthma is very common. In fact, more than 2/3 of patients will have coexistent asthma and may have a period of time where they were seeing pulmonary or going through PFTs on inhaled corticosteroids or courses of oral steroids before they get imaging and are found to have these pulmonary opacities. So idiopathic chronic eosinophilic pneumonia, the key features, it's indolent, subacute, chronic, greater than 1 month duration. The classic symptoms of dyspnea, cough, wheezing is characteristic of CEP as opposed to acute eosinophilic pneumonia where they don't really have wheezing. And then B symptoms may be present. Like we talked about, more than 50% have a history of asthma. In fact, more than 2/3. Less than 10% are smokers, so smoking may be protective. And like we talked about, peripheral opacities on imaging. And peripheral eosinophilia must be present to diagnose chronic eosinophilic pneumonia, contrary to acute eosinophilic pneumonia. So greater than 1,000 per microliter. So if you look at the peripheral smear on our Sunrise, it would be greater than 1. And then when you bronch them, they have to have greater than 25%, but usually they'll have greater than 40% eosinophilia. And very importantly, with chronic eosinophilic pneumonia, relapse is very common, unfortunately. Although now, actually, most recently, the data showing with mepolizumab, there is a sustained remission that mepolizumab may induce because you're essentially blocking the IL-5 and preventing the production of eosinophils, so preventing the eosinophilic pneumonia. So that's actually very promising for these patients. The subacute onset of cough, dyspnea, constitutional symptoms for greater than 2 weeks is how these patients usually present. And like we talked about, the BAL and peripheral eosinophilia is mandatory with the presence of peripheral opacity. So these are the suggested diagnostic criteria for chronic eosinophilic pneumonia. Subacute onset, BAL eosinophilia, peripheral eosinophilia, and peripheral opacity. Everything is peripheral. Peripheral eosinophilia, peripheral opacities, BAL eosinophilia, and peripheral or chronic onset. The classic patient here, females greater than males, usually in the 5th decade of life. Majority are non-smokers, so there's question, is smoking protective? And then, like we said, the history of atopy or asthma, allergic rhinitis, nasal polyps, eczema, etc. And up to some patients can have asthma develop at the same time as the chronic eosinophilic pneumonia is diagnosed. Some patients can have asthma develop afterwards, but the majority will have it prior to presentation or the finding of the peripheral opacities. Again, these patients will require prolonged steroids, and rarely these patients develop severe hypoxemia requiring intubation. Findings on imaging, we talked about this, they're migratory, bilateral, they're peripheral, pleural-based, ground glass opacities, consolidations, and like we said, the photonegative of pulmonary edema, and pleural effusions are very rare. Mediastinal lymphadenopathy can be present. So here you see an X-ray where you see the opacities are very peripheral, with some central, you see there's some central sparing here. This is in the X-ray, and on the CAT scan, you can see here these classic peripheral opacities, ground glass, more consolidation. Sometimes you can get reticular changes, but they're very peripheral with some central sparing. On labs, we talked about this. Peripheral eosinophilia must be present for diagnosis, and alveolar eosinophilia must be present as well. And the IgE is going to be very elevated. Usually, in up to 15%, it can be greater than 1,000, but at least in 50% of patients, it'll be greater than 100. And we don't check this, but if you check urine eosinophilic cytotoxins like neurotoxin, they will be elevated, and this is consistent with active eosinophilic degradation. If you do PFTs on these patients, because of their underlying asthma, they will have obstructive disease. Because of their peripheral opacities, they will have restricted disease. They usually have a mixed obstruction and restriction with a low diffusing capacity because you've lost those functioning alveoli in the periphery. And then, of course, the question here becomes again, is lung biopsy necessary for diagnosis of chronic eosinophilic pneumonia? The answer is no. The presence of subacute symptoms, peripheral eosinophilia, peripheral pulmonary opacities, and significant BAL eosinophilia is diagnostic. Treatment here is interesting because, of course, steroids are going to be the primary therapy, and the recommended starting dose is 0.5 to 1 mg per kg per day, slowly tapered over a very long duration of time, so 6 to 12 months. And the problem with chronic eosinophilic pneumonia is as you taper the steroids, they will invariably develop relapse. And so the question is, how do you prevent that relapse? Because the remission is very prominent. Once you start them on steroids, they get better very quickly, and you can have a sustained release or sustained remission if you keep them on the high dose of steroids. But of course, long-term steroids are not preferred. So how do we keep them without developing these long-term steroid complications? So one of the things that's being used now, like we said, is mepolizumab, because you're preventing the production or the synthesis and the maturation of eosinophils by blocking the IL-5 itself or the IL-5 receptor with benralizumab, for example, or Fasenra. A lot of these patients will put them on inhaled corticosteroids, and the reason for that is for the underlying asthma that they have as well. And then monitoring of disease activity symptoms, physical exam, monitor their CBC and the differential, pulse ox monitoring, PFTs, imaging, and usually serial BAL is generally not required. And like we said, consider mepolizumab or benralizumab therapy. So we talked about the lung-limited primary eosinophilic pneumonias. So I want to spend some time here, and I think we're almost nearing the end, but I want to spend some time talking about EGPA, or eosinophilic granulomatosis with polyangiitis, formerly known as Church-Strauss syndrome. And this is a primary eosinophilic pneumonia that is systemic, and that's very important to differentiate. If you look at EGPA, it's essentially chronic eosinophilic pneumonia with systemic involvement. That's how I kind of look at it to make it easier to understand. And we'll start off with a question. So a 42-year-old man with a 25-year history of asthma is evaluated because of more frequent and more severe exacerbations, despite an escalating therapeutic regimen. He demonstrates good inhaler technique, denies medication non-adherence, or a change in home or occupational exposures to potential triggers. While not taking systemic corticosteroids, he has a white count of 11,000 with 11% eosinophils. Absolute count is 1,200. The patient's physician is concerned about the possibility of eosinophilic granulomatosis with polyangiitis. Which of the following features will assist in meeting the American College of Rheumatology diagnostic criteria for EGPA? A, the anti-myeloperoxidase serum antibodies, or p-ANCA, is positive. B, paranasal sinus abnormalities. C, malar rash. Or D, oral ulcers. Little tricky question.
B. Sinus.
B, okay. Adam is not committing.
Yeah.
So like oral ulcers, that's the trickiest one.
Oh, okay.
That's ridiculous.
Hey, all right, interesting. So it's important. So the correct answer is B, and goes along with the systemic involvement. Malar rash and oral ulcers would be more associated with Huh? Lupus or other autoimmune diseases. And very importantly,
So you can get either P-ANCA or C-ANCA.
you can, yeah, although P-ANCA is more common, but only about 40 to 50% of patients with EGPA have a positive P-ANCA. So most patients don't have a ANCA positivity. If you're looking for EGPA and you see a negative P-ANCA, does not rule out EGPA. I will go over the diagnostic criteria. So what is EGPA? It's an eosinophil-rich necrotizing granulomatous inflammation. Like I told you, it's the only type of eosinophilic pneumonia that causes necrotizing vasculitis. It can involve the respiratory tract. It can involve necrotizing vasculitis of small or medium vessels. And it's associated with asthma is universal. So if you don't have a diagnosis of asthma, EGPA should not be suspected because asthma is almost 100% of patients will have an underlying history of asthma. And you must have, most patients or all patients should have peripheral eosinophilia. And like we said, ANCA is only present in 40 to 50%. However, systemic findings must be present to diagnose patients with EGPA. Like we said, it's very rare, less than 3 cases per million per year. No gender predilection. It usually occurs in midlife. What are the clinical features of EGPA? So like we talked about, asthma usually precedes the onset of vasculitis, usually requires chronic steroids. Chronic rhinitis is present in up to 75% of patients, and it's one of the diagnostic criteria. Relapsing sinusitis, polyposis with eosinophilic infiltration is the classic finding. Myocardial injury is not very common, but it's definitely one of the things you got to watch out for with EGPA. In fact, the most common cause of morbidity and mortality with EGPA is due to myocardial injury. So you get eosinophilic myocarditis, dilated cardiomyopathy. These patients may require cardiac transplant, but note that eosinophilic myocarditis can recur. And then it's very important that all patients with EGPA should have a cardiac evaluation, including an echo, including a cardiac MRI. They may also have pericardial effusion. It's unknown if that's because of the underlying heart failure or primarily because of the EGPA itself. So other clinical features associated with EGPA: skin changes, urticaria, purpura, nodules, neurological findings, and these are a lot of times are present on the boards. So peripheral neuropathy, most commonly you get, for example, you see a patient with foot drop or wrist drop, or somebody who's got Bell's palsy, cranial nerve palsies or CNS involvement. You can get abdominal symptoms, and renal involvement can be present, although it's not as severe as, for example, in GPA or microscopic polyangiitis. The renal involvement in EGPA is usually milder with hematuria, and it's usually found in patients who have the vasculitic form, patients who have a P-ANCA positive. And like we said, asthma is universal. However, as opposed to the other vasculitis like granulomatosis polyangiitis, alveolar hemorrhage is rare. So if you have alveolar hemorrhage, you should be thinking of other types of pulmonary vasculitis. The findings on imaging, like I was saying before, on pulmonary imaging, the findings are going to be very similar to chronic eosinophilic pneumonia. Patchy, transient alveolar opacities, consolidations, ground glass, usually peripheral. You can have peribronchial thickening or interlabial septal thickening, but very importantly is the peripheral predominance. So if you have chronic eosinophilic pneumonia, what looks like chronic eosinophilic pneumonia with systemic findings, you got to think about EGPA. You can have nodules, and they can cavitate, but that's rare. And you can have effusion, but that's also rare. So here, a classic, this peripheral ground glass opacity that can be present in a patient with EGPA. And again, here you kind of see these peripheral opacities. They can extend central, but you'll notice that the primary process is peripheral going central as opposed to central going peripheral. But you can also get central opacities. Again, here you see a patient with opacities extending from the periphery to the near center, but the center is very spared. Interestingly here, this patient also has a pericardial effusion and also has pleural effusions. What are the lab findings? Like we said, marked peripheral eosinophilia in the range of 5 to 20,000. So very, very significant peripheral eosinophilia, can be up to 80%. And the eosinophilia clears dramatically with steroids. And of course, when you bronch these patients, they have more than 25% eosinophilia. Often it's greater than 60%. We talked about ANCA positivity. P ANCA greater than C ANCA. And like we talked about, I think it's interesting to note that ANCA positivity, there's a vasculitic type of EGPA and a tissue type of EGPA. The vasculitic type is the patients that have renal involvement, neurologic involvement, cutaneous involvement. The tissue type is a patient of more myocardial involvement, abdominal symptoms, etc. The pleural effusions, if they're present, are usually eosinophilic predominant exudative. And you can get an eosinophilic necrotizing vasculitis. The only cause of eosinophilic necrotizing vasculitis is EGPA. Non-specific lab findings, we're going to skip this, it's not important, but you can have an elevated IgE, an elevated ESR, you can have anemia of chronic disease. And then you want to make sure you rule out other disease. So ABPA can look initially similar to EGPA. However, the peripheral opacities of EGPA are different than the central bronchiectasis pattern of ABPA. You want to rule out severe asthma with fungal sensitization, which is very similar to ABPA, but without the bronchiectasis. Loeffler syndrome, tropical pulmonary eosinophilia, cocaine-induced lung injury, drug-induced lung injury, etc. Very interestingly, and I don't know how validated this is, but it has been reported. In patients who have asthma who are treated with omalizumab, there have been case reports of these patients developing EGPA. However, and the same thing with Montelukast. So patients who have eosinophilic asthma that are treated with Montelukast, they've been reported to develop EGPA. However, I think it's important to note that it's not sure if it's a direct causality or if these patients had the development of EGPA that kind of revealed itself with time. Very importantly, it's not been known to occur with mepolizumab or benralizumab, the IL-5 antibodies. So I think it's when we talk about EGPA, we can look at the clinical evolution, and this is how you can differentiate between the vasculitic phenomenon or the tissue phenomenon. But remember, there can be a lot of overlap between these stages. Stage 1 is the prodromal phase, where you have the underlying asthma, the allergic rhinitis, the nasal polyposis, and then after that, you can develop the tissue phase or the marked peripheral blood eosinophilic stage. We develop the myocardial and the GI involvement. And lastly is the vasculitic stage, which has a very poor outcome, and this is the neurologic, cutaneous, and renal involvement. But like we said, only 40% of patients with EGPA will have a positive P ANCA. And this kind of is identifying the different phenotypes. There's the vasculitic phenotype, and there's the tissue phenotype, and the vasculitic phenotype will have the positive P ANCA. With the renal, neurologic, and skin involvement, as opposed to the tissue phenotype, which will have the B symptoms and the cardiac involvement and the pneumonia. So what are the diagnostic criteria of EGPA for the American College of Rheumatology, as was asked in the C question? Asthma, peripheral eosinophilia, neurologic involvement, so mononeuritis or polyneuropathy, radiographic opacities that are peripheral, sinus involvement, and then an extravascular eosinophilic vasculitis, whether it's renal, whether it's cutaneous, whatever it is, some extravascular involvement. If you have 4 out of these 6, the sensitivity is 85%, and the specificity is up to 99.7%. But again, I think if you have a patient that has history of asthma with eosinophilia, sinus involvement, and radiographic opacities, you should have a heightened awareness for possible EGPA. And then what is the treatment of EGPA? So like most other forms of chronic eosinophilic pneumonia that are not infectious, the treatment is going to be steroids. And for severe disease, pulse steroids may be given, and then you put them on 1 mg per kg for a very prolonged duration, like chronic eosinophilic pneumonia with a very slow taper. In milder disease, you can probably just start with 1 mg per kg of prednisone at the onset. Like with chronic eosinophilic pneumonia, relapses are common, and the asthma often persists. What are the risk factors for higher mortality? Age greater than 65, cardiac involvement, GI involvement, and renal involvement. These patients you would consider giving cyclophosphamide or other steroid-sparing agents like azathioprine or Cellcept or rituximab. But I think it's, very interestingly, there's a lot of ongoing studies, and we don't have final results on these. But like we were saying with chronic eosinophilic pneumonia, mepolizumab is now being studied, has been studied actually, and has shown to prolong the remission. and prevent relapse. And then the other ones like benralizumab, and I forgot the name of the new one that just came out, Syncare, I forgot the generic for it. They are being actively studied right now. So I think this is very promising that we can use these monoclonal antibodies that are less toxic than these steroid-sparing agents like cyclophosphamide or rituximab and all that. So we talked about this. Remission is so common in these patients, but they will require chronic steroids. But the 5-year survival is good if there's no poor prognostic factors. But like we said, if you have myocardial disease, high age, GI involvement, or renal involvement, prognosis is worse. And like we said, these patients will have persistent asthma. Even if they do develop remission, they will have persistent airflow obstruction. And then this is very promising for these eosinophilic pneumonias, these IL-5 targeted therapies. All right. How are we doing with time? It's too much information.
That's good.
Should we do 5 more minutes or should we stop?
Yeah.
5 more minutes?
All
right. All right. So the last form of systemic primary eosinophilic pneumonia is hypereosinophilic syndrome. This is so rare and not really tested on the board. So I'm going to I want to be very brief with it because I think it's, I think Dr. Illoway actually had a case, but I've never seen it. And I think it's very rare. But usually these patients have very persistently elevated. What was that?
I had a case with Stella.
You got a case with Stella?
Yeah.
Oh, very nice.
Hi, Stella. Where you
So these patients have persistently elevated peripheral eosinophils greater than 1,500 for greater than 6 months, with evidence of eosinophilic infiltrative end organ damage and absence of other known causes. There's no vasculitis present. Asthma is very uncommon. And there's 2 different forms. There's the lymphocyte variant, which is a clonal proliferation induced by IL-5 and IL-4 and IL-13. And then there's the actual myeloproliferative variant, which is the chronic eosinophilic leukemia, which is actually a clonal proliferation of eosinophils, actually. And these patients will have the tyrosine kinase fusion protein that's listed there. So these patients have a different therapy than the rest of hypereosinophilic causes, and it's actually a deletion in chromosome 4. Just want to go quickly here. They can have B symptoms, cough, rarely asthma is present, cardiac disease. This is tested on the ultrasound boards, but I don't think it's on the pulmonary boards. But you can develop a mural thrombus despite having normal LV function, myocarditis, restrictive cardiomyopathy, and you can develop CNS disease, so thromboembolized CNS dysfunction, and cutaneous disease as well. Actually, the cutaneous disease is one of the most debilitating because these patients can have chronic urticaria, angioedema, pruritic papules, etc. And on imaging, they can have pulmonary involvement, but its pulmonary involvement is not universal, like with the other pulmonary eosinophilic lung diseases. And it's a lot of times it's unclear, is this true pulmonary involvement or is this underlying heart failure because of the restrictive cardiomyopathy? And the BAL eosinophilia is variable. Echo and cardiac MRI are very helpful in these in hypereosinophilic syndrome. So there's the 2 different forms, lymphocyte variant and myeloproliferative variant. So if you have the myeloproliferative variant and you have this genetic disorder, the fusion protein, you give the tyrosine kinase inhibitor, and you can give steroids and mepolizumab. If you don't have the myeloproliferative variant, you can give oral steroids, and you can consider steroid-sparing agents. And now, of course, mepolizumab would be very helpful because if you block the stimulation by IL-5, you're going to prevent the clonal proliferation of the eosinophil. All right. Any questions on the primary eosinophilic lung disease?
How do you distinguish it from chronic eosinophilic pneumonia if the patient with hypereosinophilic syndrome has lung involvement?
What differentiating features between hypereosinophilic syndrome and chronic eosinophilic pneumonia? Okay, so chronic eosinophilic pneumonia will have more BAL eosinophilia with less serum eosinophilia. And then very importantly, like Andrew was saying, is that asthma is almost universal, or at least in 2/3 of patients with chronic eosinophilic pneumonia, and is very rare in patients with hypereosinophilic syndrome. But good question. Thank you, Joe.
So the latter is the big distinguishing feature because both could have eosinophils in the BAL if there's pulmonary involvement in this hypereosinophilic syndrome, right?
Correct. That is correct, Joe. And I think also the pulmonary opacities of chronic eosinophilic pneumonia are more of the peripheral opacities as opposed to with hypereosinophilic syndrome. It's not as described. Again, asthma is the more important distinguishing feature.
Thank you.
Thank you, Joe. I'm going to skip this. You guys will have the slides. So, but the secondary eosinophilic lung diseases are numerous, but the tropical pulmonary eosinophilia, simple pulmonary eosinophilia being the most common worldwide causes of eosinophilic pneumonia. ABPA being one of the most tested on the boards, but we talked about ABPA with the bronchiectasis and the asthma talks. The slides here, I basically copied the same slides, so you can have them. But what I want to do is just go to the next question. I'm going to skip the tropical pulmonary eosinophilia and the Loeffler syndrome and ABPA, but I do want to go to, we talked about ABPA last time. All right, last question. 68-year-old man developed progressive dyspnea and an unproductive cough over 1 week. He underwent total hip replacement 6 weeks ago, complicated by post-op wound infections and treated with IV bank. His prosthesis was removed 2 weeks ago. Prior isolates from his wound have included MRSA, MRSE, Proteus vulgaris, and E. coli. Current medication includes insulin, hydromorphone, PCA for analgesia, and daptomycin, on which he was placed following the removal of his prosthetic. Resting room air SAD was 71%, increased to 89% on 6 liters. Chest imaging was obtained, and this is the CAT scan finding in this patient. What do you guys see? See a lot of
pleural effusions and ground glass bilaterally.
Good, and you also see a little areas of more dense or focal consolidation. And so this is, further down, you can see it persisting. It was diffuse bilateral. So what is the diagnosis? AEP, so acute eosinophilic pneumonia. Although, what is the etiology here based on his history? We kind of talked about this, the daptomycin. So the question is going to say, which of the following best characterizes the lung injury pneumonia associated with daptomycin? A, the risk of daptomycin-associated lung injury is dose-dependent. B, lung injury associated with daptomycin is uncommon. C, the risk of daptomycin-associated eosinophilic pneumonia is associated with the duration of therapy. Or D, daptomycin has poor tissue penetration and is rapidly neutralized by pulmonary surfactant in the lung and removed by macrophage.
This is the poorly worded question, Dr. Mayo. C is correct, but B is also correct because they use this ambiguous term uncommon. Does that mean less than 51% of the time? Or?
That is a good point, Fury. I just copied and pasted C, but I didn't even think.
Yeah, no, I should send them a comment actually.
So the correct answer is C. I guess when I first looked at the question, I think D tricked me a little bit, and because this is actually a true statement. It's a true statement, but not what they're asking for. Not the cause of the lung injury pneumonia associated with daptomycin. What are other drugs that cause eosinophilic pneumonia? 13 still correct. Minocycline, yes, that causes eosinophilic pneumonia. Like Dr. Mayo was saying, cannabis, cocaine we talked about. Trying to see what other drugs we use commonly. A lot of our patients who get chemo and develop pulmonary opacities, I guess it's something we have to think about. We use chloroquine quite a bit. Chloroquine? About a year ago? That is true. That's an interesting point. A lot of chloroquine was used. Sulfonamides, NSAIDs also are in this list of drugs. ACE inhibitors have been known to cause eosinophilic pneumonia, although very common. But it's kind of a list of drugs that can cause drug-induced acute eosinophilic pneumonia. Eating too much poultry will give you tryptophan. Turkey, like eating turkey on a daily basis. Thanksgiving, we should look it up. We should look it up. Incidents of you need to like truck worth.
You know what Kelvin does with things,
It's just a normal 30.
So I'm done. I think we talked about everything. We went over the eosinophil, or over eosinophilic pneumonias. We differentiated primary from secondary, discussed non-limited acute and chronic, and then the systemic. And I'll give you the slides for the parasitic infections that are sometimes on the boards. I don't know if they're really tested on the boards, Fiore or Andrew. I'm not sure.
There's one on the in-service.
Yeah, the helmintic infections.
Oh, yeah, there was one on that. There was one on the service.
All right. Any questions from anybody?
It's good as black exorcist.
Thank you, guys.
Thank you.
Thank you. Thanks, Nina.
Thank you, guys.
Yes, block eosinophil proliferation.
Yes.
Am I right in saying that no one's detected a complication related to infection that drives to that?
It's a good point. That I have had a patient that developed herpes zoster shingles.
About like worms?